My name is Jane South. I'm Professor of Healthy Communities here at Leeds Beckett University. And the first thing I'd like to do is welcome everybody here to this seminar, Same Storm, Different Boats, COVID Community and How We Come Together. And different boats, COVID Community and How We Come Together. And if you haven't been to the university before, welcome as well. Some people have, and some people have even been students here before, but you know, it's good to have everybody here. So this seminar is part of the Centre for Health Promotion Research Seminar Series. And if you don't already know us, the Centre for Health Promotion Research is a very long-standing UK research centre. We've been going near 2027, isn't it? Yes, Anne-Marie's our director. And in the centre we have three research themes. We have a research theme about healthy communities, and that looks at the sort of community contributions to public health and health promotion, and what communities can and do that contributes to health and well-being. We've got a theme around health inequalities, and we particularly focus in that on working directly with people and groups who are most impacted by health inequalities, and using different research methods to include people. And we've got a stream on evidence and evaluation, and that's where we do some of our methodological stuff, but that also links and underpins that multidisciplinary. All of those research themes speak to the seminar that we're having today, which is looking at COVID and community and the sort of lessons learned from it. So it's also, I think this seminar is a really important person to talk to us on this topic, who's had very first-hand experience, because it was, I think everybody will agree, a really significant period in our public life. And for me, I feel very passionate about that we do learn the evidence, do learn the lessons from COVID. And myself and Jude Stansfield, who's here, were both working. We're now, you know, full-time sort of academics, but we were working then during the COVID pandemic in Public Health England, and we're part of that in advisory roles, trying to encourage the fact that the national response should be thinking about communities a little bit more than it was. And we were also involved a little bit in the development of the national COVID champion programme. So it's great that and the talk will. So I'd like to welcome our speaker and panel. Jason, who will come up, it's just about to come up, I just asked you to come up in a minute, is Assistant Director of Prevention and Healthy Lifestyles at the Health Foundation. And Jason has a huge experience, 25 years, and critically for this seminar and for the book that he's written, he was DPH of the London Borough of Newham for 6 years, which included the COVID pandemic. And I think we met on a couple of Zoom calls, didn't we, over the Community Champions programme. So, and he won't probably do this, but I'm going to just plug his book, because his book is an amazing read. It's really, really interesting and readable, and gives you a sense of what it was like in a London borough managing the pandemic, and raises all sorts of interesting issues. After Jason's talked for, he's going to talk about his book and what it says and do some reading from it. We've got a panel discussion, and we've got two panel members here. We've got Raheem Mohammad, who's the director of Hamara, which is the largest ethnic minority organisation in West Yorkshire. And in fact, the university's had a lot of contact with Hamara over the years, and we very much value those partnerships. And Raheem is a professional youth worker and a quality of future generations. And I think we should recognise that the leadership role that Raheem played and plays in the city, as part of a sort of leader of a large third sector organisation. But I know during the pandemic you had a very key role in how some of the things were organised at a sort of community level. We've also got Victoria Eaton, who's our DPH, and she's been the director of DPH at Leeds City Council since, I think, the beginning of 2020.
The 1st of March.
1st of March, which perhaps wasn't the best time to take on that role. But you've worked in before that. You'd worked to take on that role. But you've worked in before that. You'd worked very well known in Leeds because you worked in a number of public health roles across the city since 2007. And Victoria led the improvement of significant public health programmes and services, including achieving outstanding CQC ratings and ensuring a strong post-pandemic focus on inequality and long-term investment in communities. And as well as being the local Director of Public Health, you're the Director of Public Health member for the Yorkshire Integrated Care Board and co-chair of the West Yorkshire Health Protection Board and a member of the National Care. Very experienced panel and speaker. And what I'm now going to do is ask Jason to come up and to start us off by talking about.
It's great to be here and great to do this as part of an event for the Centre for Health Promotion and Research. I've, since kind of discovering Jane and Jude's work during the pandemic, I think it's so important. Community approaches to public health are absolutely in my core. Very great to do this, have this discussion. Right, I'm going to start by reading something from the book. I should remember when I first heard about COVID-19, just as I remember other significant, tragic, global, national moments. When 9/11 happened, 7/7, the Grenfell Tower fire disaster. But I don't. The journey into COVID happened in slow motion at first. Initially, it appeared as an emergent virus in Wuhan province in China, not a place I'd heard of before. On January the 4th, 2020, the World Health Organization shared news on Twitter of a cluster of cases of pneumonia from Wuhan with no reported deaths. A week later, the WHO issued a statement saying, no clear evidence of human-to-human transmission of the novel coronavirus. But things were starting to escalate quickly. As the month went on, what was happening in China seemed straight out of Hollywood movies like Outbreak. What was real? What was not? How much did the particularities of China with censorship and the difficulties of reporting cloud our understanding of what was really going on? Whole towns were being constrained in their daily movements due to the virus. Really? Okay, but this is China. They operate by different rules. It was another month before the first case was identified in Italy. That started to change perceptions. But only partially. The scenes on the news were awful. People crowded on trolleys in hospital corridors, despairing dispatchers from intensive care units, scenes of police guarding the outskirts of villages so people couldn't leave, significant levels of death and distress several times, and much more similar to our life in the UK. Yet somehow what was happening still seemed distant, too fantastical to be true, too unimaginable to believe that it might be coming here and turning our lives upside down, until it did. It was a completely extraordinary time, the whole world. And for us here in the UK, absolutely transformed and turned our society on its head for a period of time. 200,000 lives were lost due to COVID, so many people bereaved, many others affected in countless ways, people who lost loved ones, mental health was impacted, livelihoods lost, family lives, school lives disrupted in ways that before it would have been totally unimaginable. And one of the really interesting things since I released the book and have been talking to people about it. The most common thing that people have said to me is, this is not something I wanted to return to. This is like too painful. I did not want to go back to COVID, even though we're 5 years on. The sense that the scars haven't fully healed. It's not something that people wanted to think about. Something that people wanted to think about. So I was Director of Public Health, as Jane said, in Newham. Newham is a borough of East London, an amazing, wonderful place. It's one of the most diverse places in the country, population of 375,000, dynamic community, people from literally all over the world, a thriving community life, lots of religious life, a place of enormous growth, London's Olympic borough. Also a place of a lot of challenges, huge housing challenges, enormous overcrowding, huge amounts of multi-generational living, dynamic, interesting, but a place of many challenges. And as a public health team, like public health teams up and down the country, and Victoria, I'm sure, will talk about what happened here in Leeds, we did something completely amazing, extraordinary. We worked in ways that we never would have imagined working before. We set up food distribution hubs and developed advice working before. We set up food distribution hubs and developed advice and guidance for everywhere and anywhere, from care homes to mosques and gurdwaras to undertakers and anyone you could think of. We set up testing facilities, open vaccine hubs, and hundreds of other things. We worked at record speed and we did things in days and weeks that normally you'd think would take months, and years. And like I say, these things went on everywhere, but it was an extraordinary experience to go through. And then just as COVID was starting to wind down, in fact, long before the WHO formally announced the end of the pandemic, there was a real sense that the world had moved on. Russia invaded Ukraine. There was a huge spike in energy prices, which led to a Liz Truss budget, which led to more inflation, a cost of living crisis ensued, and a whole range of other challenges emerged. And we moved from COVID crisis into perma crisis. And before long, people had kind of started to forget about what we've been through. And something I noticed was that this team that was in this public health team, where we'd gone through this amazing journey, suddenly we had some new people joining it. Brilliant people, brilliant younger people coming from university, for example, who hadn't gone through that shared experience. And it struck me how quickly we move on and how quickly the shared experience just becomes history. And I felt what we'd done in Newham and what people had done up and down the country needed to be written down. And that was when I first thought about I wanted to tell. It wasn't so much about pandemics and pandemic preparedness. I knew there's going to be a gargantuan public inquiry that will finish soon, which will have thousands of messages about future, how we prepare for future pandemics. When I sat down to write it, the truth about inequality and the way that the pandemic was that spotlight on inequality and about the power of community. So that's what I'm going to focus on. So let me start with inequality. On April the 5th, 2020, something astonishing happened. The Prime Minister, Boris Johnson, was admitted to hospital. He was admitted, and over the first few days, it was really unclear how his condition was. It became clear he was admitted to ICU, and it seemed it was very serious. As the days went on, the news suggested he was recovering, and eventually he was discharged. I'm going to read again. For those few days, the Prime Minister's predicament reinforced a feeling that existed in the early days of the pandemic, namely that we were all in this together, equally impacted by the cruel virus. If the virus could get to the Prime Minister, none of us were safe. And of course, that was true to some degree. But it soon became clear that the risks for some people were lower than for others. It seems obvious with hindsight, as it often does, but those of us watching most closely had only just started to think about the potential ways in which social factors might be having an impact on individuals who are most at risk. The first indicator for me was a tweet I saw on April the 3rd, tracking the pandemic in the early days in the US. The COVID-19 death rate highest in Metro Albany, Georgia, New Orleans, New York, and Detroit. Death rates higher in colder, wetter, and denser places, and with higher Black, Asian and Hispanic share. Tweet from Jed Colgate. Operating that meant people from minority groups could have disproportionately higher mortality rates from COVID. At this point, so early in the pandemic, there was very little published data to go on. And it was too soon for peer-reviewed journals. Twitter would have to do. So we started to think, what was it? Because we were just at that point very, very early trying to understand the nature of this virus and starting to hypothesize what about the social factors could be making certain parts of our population more at risk both of catching the virus and secondly more at risk of both of catching the virus and secondly more at risk of having the worst consequences, being admitted to hospital and ultimately dying. So those of us working in public health, health inequalities are nothing new to us. That's our daily work. But across most times in normal times, health inequalities play out in a myriad of complex ways across a life course, affecting people in all kinds of different ways that lead to unequal health outcomes throughout life. But here, it was staring us in the face. As we thought about it and as we understood the data, we could see, and I could see in Newham, the inequalities manifesting in so many ways in the work people do. So in Newham, people who are far more likely to work in service jobs, out in the community doing care roles, in transport, retail, security. They were much less likely to. There was inequalities in the transport people use. In Newham, fewer than half of the population have access to a car. They were out and about trying to get to those jobs on the buses, much more likely to be exposed to the virus. They had faced risks by the housing they lived in. As I said before, we have hugely higher rates of overcrowding in Newham, so people much more likely to be spreading the virus within their homes, but also really high rates of multi-generational living. So some people of working age out at work in those service jobs, but then coming home and putting at risk their parents or older relatives who were in other contexts would be shielding away from people exposed to the virus. And there were much higher underlying health inequalities. So the rates of diabetes and other cardiovascular risks that we were beginning to understand place people at higher risk for the worst outcomes from COVID were much more. But these risks were brought out by the evidence. So we could see it there, it was happening. You could see in real time the way inequalities were playing out and leading to these different health outcomes. There are a couple of particular moments that had quite an impact on me. I was doing a Zoom conversation going back to school. And like my children, they were mostly looking forward to going back to school, ready to escape the monotony of life at home, reconnect with their friends, just get back to something that felt a bit like normal life. But what was different for some of these young people is that they lived with their grandparents. And they were going back and they were going back to school with a deep worry and a deep concern that by going back to school, would they risk catching the virus and bringing it home and infecting their grandparents who they were living with? And that was a massive difference. My children didn't worry about that. They would visit their grandparents from the safety of a doorstep. And another thing which really struck me deeply was when we did some research later on in the pandemic around barriers to isolation. I knew the community well. I knew the poverty and the hand-to-mouth existence that many people lived with. So it wasn't a surprise to me when we asked people, what are your barriers to isolating, or what are your barriers that they worried about losing income from work? What shocked me deeply to my core was that wasn't the number one answer. The number one answer was that people said they feared losing their job, that the level of job insecurity, of precariousness of people's working lives was so prevalent in the borough that people felt it was to live with the consequences of what they may need to do. So inequalities was playing out in such profound ways. One of the other things that we saw in real time during the pandemic was the disconnect between policy and impact with a view to inequality. So policy designed for was first introduced. It was introduced at drive-through centres at the edges of towns. Well, what did that mean for a population who largely didn't have access to cars? or the isolation policy, which initially, when implemented, expected people all to be able to isolate and receive a wage. It took ages before things like a test and support and receive a wage. It took ages before things like a test and trace support payment was introduced to help people on the low incomes manage. Or when the vaccine program started, and we were told that the vaccines were going to be based in large mass vaccination sites, again at the edges. And we said, we know the community at the edges. And we said, we know the community, people aren't going to go. And it took a long time before that policy changed. So, like I said, to those of us working in public health, these inequalities aren't new. But what was so different about the pandemic was about seeing both the impact of inequality in real time. And I think there's something that we can hold on to from that, because there's something in the moment of the pandemic where health inequalities did touch a public consciousness in the way that it rarely does. So the other thing that I wanted to touch on was the power of community. So in May of 2020, the Office for National Statistics released their first report on mortality from COVID by area. Now, London had been at the forefront of the first wave, and this was still pretty early in the first wave. So most of the areas that had the highest mortality rates by the time that first report were published were in London. But Newham, the area that time that first report were published, were in London. But Newham, the area that I was DPH of, was at the top of it. Not something you want to experience as a director of public health. We were, not surprised, but devastated, trying to sense make. You're conscious of the things you can't control, but you do a job like this to shape and support and help your community to navigate the challenges. And over the weekend after that report was published, I spoke to the Mayor of Newham and to the Chief Exec, and we spoke about it and we reflected on it together, and we asked the questions, what more can we do? What more should we do? We don't know how long this pandemic is going to last for, the vaccine. And one of the things we reflected on was community. There'd been a lot of community response in the first wave, amazing mutual aid groups that I'm sure people here were part of, started by notes on lampposts or through letterboxes, WhatsApp groups to support people in their community. Hundreds of thousands of people volunteered as well. And we did loads as a team to work out how we navigated the challenge together with community. I'd worked on the Grenfell Tower Fire Disaster Recovery, and seeing the best thing I'd seen was this community champions work where trusted relationships were built with a community that in other ways trust had completely evaporated. And the Mayor of Hurricane Katrina, where community navigators help people manage in that enormous crisis. And we wanted to build something on that, and we developed the idea of COVID champions. To do it well, we thought we needed to go really, really wide and reach out right across the community. And we used all the channels we could, really, really wide, and reach out right across the community. And we used all the channels we could to try and recruit people. I brought in an old friend called Anne Bowers who came in to help lead it. We put on 2 Zoom chats per week, set up 2 WhatsApp channels, one for discussion and one for dissemination. And from the beginning, we had some really important principles. The first was there was going to be very low barriers to entry. Anyone who wanted to participate in this was very welcome. There was no minimum expectation of how to be a COVID champion. You come and you get involved in whatever way matters to you. Secondly, it was as much about listening as it was about talking, which is out to the community. But as important, it was going to be a way that we could hear back from people in the community about what was going on for them, what mattered to them, what we needed to know about. Thirdly, it was going to be absolutely rooted in honesty and transparency. We would share everything we knew and be able to say we knew and be able to say sometimes we don't know. And actually, I learned deeply the power of being able to say I don't know in many of those contexts. And finally, we built it with a spirit of warmth and human connection. We were doing something incredibly serious. And in fact, many of the first champions who joined us were people who experienced bereavement and loss in the first wave and wanted a way to give back, make a positive contribution, get involved. But we were able to do that with a sense of community, building a sense of people wanting to share. Building a sense of people wanting to share a space, an online space together, to hear each other, to be together, to go through the journey of the pandemic together. At its peak, we had 500 members from incredibly diverse backgrounds of age, ethnicity, and people did diverse backgrounds of age, ethnicity, and people did their role in vastly different ways. Some people would just turn up and listen and speak to the odd friend. Some people would we'd send JPEGs out of new information and advice on WhatsApp, and some people would print them out and put them on lampposts and in shops. WhatsApp, and some people would print them out and put them on lampposts and in shops in their neighbourhood. Someone else would send them to every single mosque in the borough. People did their roles in different ways. And what we created was a few things. We created this incredible cascade mechanism. We could send things out and then it would multiply hundreds of times across the community. We created an early warning system by listening to the community twice a week and on the constant WhatsApp group. We knew what mattered to people, where we needed to do things differently, where things weren't working, who wasn't being reached, what issues weren't being touched on. And most to my surprise, we became a community that we navigated the challenges of the pandemic together, a community that was built not on typical power relationships between government and community, but on a true sense of trust and common purpose. News about the work spread very fast, and we would run workshops, and eventually it became a government policy, which Jude and Jane were involved with. And it was something that we were deeply proud of, and it was something that was very, very profound to our experience. In November 2020, that early warning system kicked in, and the vaccine program about to start was spreading in the press, and the community was saying to us, you know what, people are worried. There's a lot of nerves about the vaccine. People were particularly worried about the speed with it being approved. Was it really going to be safe? And we're telling us we needed to do more work on that. Be safe. And we're telling us we needed to do more work on that. So based on the same principles that we developed the whole champions, we carried on that work, but we doubled down, creating vaccine champions, working in a non-judgmental way, totally honest. There was lots we didn't know. Democratizing access to expertise, bringing in paediatricians, vaccine specialists, others, so people from the community could ask all of the questions that they had. In February 21, we convinced the NHS to let us use things that weren't the mass vaccination. Faith communities across the borough asking whether they wanted to host vaccine clinics, and was completely overwhelmed by the response. People were really, really desperate to be involved, and initially far more than we could handle. And ultimately, tens of thousands of vaccines were delivered through all kinds of community outreach venues. In the summer of 21, we held a celebration event for the vaccine work that we've done together as a community, and this is the last bit that I'll read. We heard about the challenges that adult children of older migrant parents faced, where language barriers. We heard about the challenges that adult children of older migrant parents faced, where language barriers, digital access, or basic cultural navigation meant that invitation letters would have gone unread if supportive children had not opened the post, made appointments, and escorted their parents to the vaccination centres. We heard of imams and priests who had convinced people about the importance of circulating within people's Facebook streams. We heard of persuasive and encouraging GPs who, with great tenacity, had supported people who were unsure. And we bore witness to friends who had given other friends the confidence they needed when they were otherwise fearful. And there were so many other examples. We began to talk about how it takes a village to forward take up. The relationships that I made with people across our community will stay with me forever. But the experience with our champions and those local community organisations, I think, speaks to something of really great importance today. In this era of alienation from government, institutional, I think those ways of working speak to something different, based on human connection, common purpose, honesty, respect, and deep collaboration. Working that way brings deep outcomes of reaching people we otherwise wouldn't have reached, where it was often lacking, and supporting a whole new group of community activists committed to make a difference. as I was thinking about what I was going to say, I thought about this next thing, and I hope it doesn't sound too over the top. But I was thinking about Abraham Lincoln's Gettysburg Address, which spoke of government of the people. Abraham Lincoln's Gettysburg Address, which spoke of government of the people, by the people, and for the people. But perhaps the lesson of the pandemic, and one answer to the challenges that we're facing today, is to add government with the people. It strikes me that if we took two things from the pandemic, one about inequalities with it staring us in the face, and secondly about the power of government with the people, then we'll have learned two important lessons. Thanks.
It's a really inspiring talk. Do you want to proceed? Because we're going to go into panel. Okay, so we're going to have a bit of panel discussion and open it out, if that's okay. So I wanted to start by asking you both, Raheem and Victoria, if you could give your reflections on Jason's talk and how you think it relates to your experiences and whether there's anything that particularly resonated with you. Raheem, do you want to give a go?
So I was thinking whilst Jason was speaking about my experience of the pandemic, other than getting my first grey hair, having two kids, lockdown kids, and cutting my own hair as well. It was a very strange time for myself and the team. Same storm, but having different boats. But we often experience in our sector around communities that actually have a lot of experience of negativity prior to the pandemic. And that was just a place to surface those inequalities as well. We learned that culturally, sometimes diverse communities offer their experiences systematically as well. But within Hamara, we really experienced initially at the start that sometimes we think there's something best for communities without asking them. So very early on, I spoke to Jason about this. One example that we worked with the council was we soon established that the food banks within getting the same thing, which was given out through surplus food. So we sat down, we spoke about actually what are the biggest groups of ethnic communities across Leeds, and we established that they were the South Asian, Middle Eastern, Eastern European, African, and Caribbean. Then we asked actually what do they eat on a daily basis, and we went through their staple food items. So we soon established that actually there was a bigger need than we thought there would be. So we started off in Hamara just supporting the South Leeds communities. And then we realised actually this is a city-wide need. So we spoke to public health, we spoke to our authority colleagues. And we became this culturally appropriate food bank and hub. Until this day, we work with organisations across the whole of the city, supporting their communities with culturally appropriate food. So I think it really helped us really dive deep in what they require as well. And on the flip side to that, when it comes to community engagement, we ensured that we as a trusted organisation were trying to translate actually what the policy required from our communities, the test and trace, what was required from that, the vaccinations we did. So what came from those was scary, astonishing, but we tried our best to make sure everybody who were trusted in communities were vocally speaking about actually what the myths were and how to break down those myths as well. So a lot, and what you said actually related a lot.
Shall I go, Jane? Shall I go, Jane? It was so interesting, Jason. Thank you so much. It's brought so much back. Oh my goodness, yes, of course, remember that. I think it was really powerful how you brought it across with those themes around inequalities with the examples you gave and the communities with the examples you gave, because I think in the years that the pandemic was with us and its different phases, kind of different parts of that really played out, didn't they? And so I would completely agree and share like thinking properly about people just the thinking properly and listening and understanding, and therefore reflecting in actions the way people actually live and work, rather than just a kind of an assumption of what would be an easy the way people actually live and work, rather than just a kind of an assumption of what would be an easy an easy way for people to live and work, which isn't based in reality. And the examples you draw, I think, are some of the critical ones that we also remember really well. I think easy way for people to live and work, which isn't based in reality. The examples you draw, I think, are some of the critical ones that we also remember really well. I think on the inequalities point, it was so interesting because, as you say, often people are usually surprised by the way the pandemic played out in populations, because we know that's what happens with lots of infectious disease and lots of other kinds of disease, because that's what we do, isn't it? But actually, it was really interesting that so many other colleagues and partners were very shocked with what they saw, and inequalities come to life like that. I remember talking to a medical colleague who'd worked in the city for years as a GP, and never really saw inequalities until the pandemic came along, and then actually thought, my goodness, inequalities in all sorts of living conditions and working conditions really played out was a surprise to some people who you thought would be more au fait with inequalities. And I think that often, and it's an opportunity for us, isn't it? Because as one of the things that we did as a city, and I'm sure Jason did as well, was say, actually, if we put a map up for another, disease, or we put in a healthy life expectancy map or a life expectancy, it's the same map. I could say this is the COVID deaths and infection map, and this is the map for pretty much deaths and infection map, and this is the map for pretty much any other public health issue, and it is the same map. And people were genuinely surprised by that, as if COVID was something different, as if this thing was something different. So I think in a way, even though all the challenges it brought, there was an opportunity there to people to really understand this is how things do generally play out, really. This is not a surprise. I always remember I had a journalist from the Guardian newspaper ring up and ask for the latest commentary on at the height of the pandemic. Leeds came, there was a bit of a thing, wasn't there, about trying to avoid being the DPH on the telly. And I remember talking with my politician to say, thank goodness that's not us, but let's not be second, And we managed to stay off the telly until October 2020, when there was the student return, and actually they'd said we want all the students to return. And we've got 80,000 students that come in to return. And we've got 80,000 students that come in. So obviously that's when we hit the TV. And I was talking to a Guardian journalist who called up to say, we've never heard of directors of public health before. Maybe we should know about you. We should know about you in the future. And actually, it took the pandemic for that to happen. So there was loads of that interesting stuff. But that thing about inequalities really came through, and I think made it more understood by a greater group of people than use of challenges. I think the point around communities, around and all the points you make around levels of trust are really key. And I guess just briefly, one of the things that felt really pertinent to us when we were looking at learning from pandemic, sustainable, kind of positive relationships with communities and third sector organisations as something that kind of pays dividends in times of crisis, but actually you absolutely don't wait for times of crisis to start paying attention to that. So I think as a city that there was conversations around relationship with communities and the levels of trust in communities, and works organisations such as Hamara and others a much better place to do that than people like me coming into a community. It's just good practice and common sense. But I think often what we've seen is people disinvest in peacetime and then feel that they need to then all of a sudden do that, and it just doesn't. It's not sustainable. So there is something about those long-term relationships. And I guess the last thing I'd say was we have this sort of sense of all of the really challenging things that I'm sure we all went through in the pandemic were incredibly, difficult, and we all, went dug deeper than we've ever dug. But the communities themselves really kind of stepped up in ways that you wouldn't have ever thought possible. Like you say, Raheem, around some of the food banks and the humanitarian support that happened across communities, and that felt actually quite uplifting. And I think some relationships were forged in that time that are still strong now, almost because of the pandemic. So, I think we need to balance off a lot of those strengths as well.
Thank you. Yeah. I was going to ask a question about place, because Raheem and Victoria, you've reflected this a bit, but it's very strong in your book, Jason. The need for the need for local grounded knowledge of communities and knowledge of your place driving what you did in Newham. And I wonder if you could all reflect really on how important to have that sort of drive that local response to emergencies, whether it's a pandemic or a climate emergency or cost of living or whatever locally, or is it something, is that only part of the picture? I think that's because there's lots of things in common, but Newham ultimately is quite different from Leeds, and London is different from the news about the television. Sort of, saying we've got to do this differently in our area, because this is what it's like for Sheffield or Gateshead or whatever. Yeah. I don't know if you want to go first.
I mean, I'll have I think it's about, there are certain things that make sense to do for a country, right? You don't all kinds. We couldn't develop vaccines for our places, and nor would we need to, because a vaccine works the same for everyone. And there are less extreme examples of things that need to be done for a country. But I think the balance is how you find that right balance between what needs to be done efficiently for a country that everyone's going to use in one way, and then what needs to be applied locally. So I think the vaccine's a great example. Developing a vaccine, buying a vaccine, probably distributing a vaccine, all makes sense to be planned in a national system. How you actually get the vaccine to communities at a local level, that knowledge actually is really important and meaningfully applied. So that's where the tension came in that bit of the example, when suddenly national policymakers were telling us what was the best way for us to get the vaccine into our communities. So I think it's about in every time thinking about what's the best geography to apply something. There's another example I write about in the book, which is the second wave. And the second wave again started in East London, where I was, and it was terrifying seeing why the numbers were going up at that time in the way that they were. And we were being told, you need to do more to stop the virus, to stop London going into lockdown for Christmas, because people need Christmas. And on that one, it was like, well, we haven't got the tools. Like, there's nothing that this is a global city in which people. Well, we haven't got the tools. Like, there's nothing that this is a global city in which people move and live, and viruses spread. Actually, we have got that didn't make sense to be giving that local responsibility, because they were asking us to do something that was completely beyond our capability. So it works in all kinds of different ways, but the fundamental asking us to do something that was completely beyond our capability. So it works in all kinds of different ways, but the fundamental question is, what's the right for any given issue? What's the right geography, and if possible, do things closer to community. But that doesn't. There are lots of things, like I say, lots of things makes different levels of geography.
I think from the VCSE sector example, which really struck out to myself whilst I was thinking about it, was the model of the community care hubs that came into Leeds. So immediately the city identified what organisations were visible, sense a point of anything that's required from that community there as well. Having that model there as a city really helped us really navigate what was required and who to go to. And we went on the vaccination tour or the bus tour. It really helped us place where it had to go to at the same time as well. That's still very much in place. So now they've become the Leeds Community Anchor Network, very solid in communities and continuing that resilience, but also that reactive, supportive man at the same time as well.
That's how Leeds interpreted national policy ultimately, yeah.
And it's an interesting one with Leeds as a city, because unlike many of the other core cities, I mean, obviously London's very different, but we have a highly urbanised city centre, and then actually go out to market towns and villages and a lot of green space. So the sort of totality of Leeds is actually many places. The sort of totality of Leeds is actually many places and different communities that actually identify in different ways some of the time. So actually, the approach we would take in Harehill, the very dynamic, diverse inner city, different than how we'd work in Otley as a market town, and it needs to be. But so I think I completely agree with the point about different levels of geography, but as close to communities, start off as local as you can. I guess what was really interesting. Well, there's two things really. There was one thing about a controversial thing to say, but there was a real numbers game that was playing out in the NHS. So as long as you got the numbers, then actually the numbers was what mattered. So the big vaccine centres were there to get as many people vaccinated as possible. And actually locally, we didn't just want to chase the numbers. We wanted to if all of those locally, we didn't just want to chase the numbers. We wanted to if all of those numbers were in our green leafy suburbs, we weren't doing well. So we wanted to look at where we wanted to make sure our people could access vaccination, for example. So there was something about being the champion for actually not just chasing the numbers. And then one of the other things that was interesting that played out politically, and the media were quite instrumental in this as well, was almost that thing about wanting a story which was about how different communities were being almost. So there was a lot of work done locally to dispel myths around, there's all this disease spreading in this community, which was really fired up by the media. And actually, there was a lot of work done with local politicians to really come back clearly with the evidence to say that's actually not the case. We were not seeing infection rates rocket in this community, and so coming together as Leeds as a city then felt really important, because if we didn't manage that really positively, I think we'd have had more. If we didn't manage that really positively, I think we'd have had more community tension. And actually, it felt. I mean, I'd be interested in people's views, but from my view, it felt like we'd never got to a place that I think some other places did, where there was, for example, places like Bolton, Oldham, Rochdale in Greater Manchester, because the virus was so prevalent in particular parts of town, which also had a particular ethnic diversity, and therefore it stoked community tensions and racism and a wider response. So to manage that really carefully with a factual approach that actually, that wasn't something we were seeing in Leeds, but could have played out if we didn't manage that really carefully.
And thanks, that's really helpful. I was going to ask, because I want time for people to come in and ask. I'm sure lots of people have comments. Looking forward now, you touched on it a bit, Jason, but what do we really need to take into public health practice, well, it's not just public health practice, is it? It's sort of how we support and enable communities, but what do we healthy and well? What is the key learning for you and Victoria? What do you?
I think it's what I said at the end of mine, which is, like I said, if they take two lessons from it, it's about it's about trying to tell stories in that way about inequalities, that highlights it for people who actually did, as Victoria said, recognise it in the pandemic when they maybe didn't before, and not to lose that, and what the implications of that are for the policies that we should have, the practices we should have, and and to build on the work that we did working together, that the relationship between government and communities and people isn't just transactions. It can be one of common purpose, and it feels, since the pandemic, for all kinds of global reasons, issues of trust have become ever more challenging and serious. And it feels to me that, in a way that we wouldn't even thought about a few years ago, that even some of the basic kind of principles of democracy are challenged by people. And I think, so this gets really to the kind of the fundamental core of how you develop a shared society. So how you develop a shared society. So I think those things that we learn, those muscles we built in COVID around this, are ones we need to keep using.
Okay. I'll probably talk around about the before a crisis happens or is impacted by us, and I think the pandemic really showed us as a society actually the importance of ensuring that community organisations are supported for the long run. Another thing that I really, whether it was sharing information around the myth busting or fact finding or conversating with a particular group of community leaders, is that trust takes a very, very long time to build, and we have assets within the city that are already there that we should utilise. We do say to our colleagues across the health and the public sector that actually these are your assets to the city, utilise those and work with those. And I think Leeds is really fortunate in that way, that actually we do work really closely together. Part of the National to Neighbourhood Health Improvement Programme, the sector is very much involved in the development and the planning of that as well. So it's really good to see that as a sector we are still very much involved in that, as we feel like it's important to continue to do that as well.
Trust is a really key theme, isn't it? With so much of it, and such a magic ingredient.
Yes, I mean, I'd agree with everything Raheem's just said.
Magic ingredient.
Yes, I mean, I'd agree with everything Raheem's just said. The first one, particularly around investing in communities in a sustainable, long-term way. I think that's something we should all challenge ourselves to do, and through our third sector organisations in a sustainable, long-term way. You picked up on it, Jason, when you were talking around. It's a kind of a values piece, and there's obviously there's the whole thing around using all the brilliant work that you've done over the years, Jane and Jude, around community-centred approaches, and really challenging ourselves around how we're putting those approaches. So part of that is a kind of a shift of sort of assumption that there's a professional top-down approach that knows best and kind of does things with two communities out there, to a sense of sort of changing the dial on that, and to a sense of sort of changing the dial on that, and that's about the way we work, but how we can influence others to work as well. And there is something about having some humility in that approach, and actually listening really hard and really valuing the concerns people have. I think there's something really important about taking those concerns very seriously. So when people have questions and queries around the vaccine, any vaccine, or any issue, actually putting in the time to really listen and take those concerns seriously, rather than just think there. And I think that we've got a long way to go on that, about really putting in the time, because actually there's loads of things that are not straightforward around health. Screening is a really, really complex area, and actually it's up to each person to make their own informed decision. Now, most people think you should just do it because that's what your GP might say, rather than actually it really is up to you. You need to understand and weigh up, so I think to get into a different dialogue where actually it ultimately is the call of local people, how they choose to take charge of their own health, higher of X, Y, or Z. I think we need to get in that space. And then the last thing I'd say is that public, where public health sits now in the system is in local government, and some of our biggest kind of champions of a lot of this approach are our local elected members. We did so much great work, and a lot of our local elected members come from the communities they serve. So I think there is something quite powerful in the way that local government works, which is democratically accountable to local people, which is, it's not about us doing this on our own. There's actually lots of our local government colleagues who are rooted in this kind of approach, and I think that there's something really positive about working really closely with that and learning from that ourselves. So yeah.
It's like a culture shift, isn't it, really? It's, yeah. Thank you. I'm going to wind up the seminar now. Before I thank the speakers, just to remind you that this is a series of seminars. This is our next seminar. If you want to be on our mailing list, you will get a little email from following the seminar today, and please reply to us and let us know if you haven't already. Seminar today, and please reply to us and let us know if you haven't already done it on Eventbrite that you want to continue to receive information about CHPR seminars. So, because we'd love to see you, and what I want to do now is just to thank Jason for brilliant book, brilliant talk. Just